I'd like to welcome everyone today. I'm Keith Boswell. I'm the Vice President of Marketing here at ADHD Online. And today we are having another one of our webinar series focused on understanding the complexity of ADHD. We're very fortunate to be joined by one of our practicing psychologists, Dr. Gregory Harms. Dr. Harms has over 20 years experience in clinical practice and also does alcohol and drug counseling. So he's got a lot of background, a lot of experience in ADHD and other mental health conditions. So we've done another understanding ADHD earlier in the year. I made a technical gaffe and didn't record about half of that webinar. We've had a lot of people asking for it. So we thought rather than try to patch one together, we just do another. And then next week, we'll also be doing one on the non-pharmaceutical options for people with ADHD. You know, a lot of what you hear about is the standard course of treatment, which is stimulants for most people, but stimulants don't work for everyone. So there are a number of people with ADHD that choose to look at a number of different methods for dealing with it. So Dr. Harms is going to join us again next week for that. We hope you will too. So I'll quit talking for now. I'll be the moderator later. So I'll be representing all of you today. Please, throughout the session, add your questions, comments, either in the chat or the Q&A down at the bottom. Again, today we're going to be talking about understanding the complexity of ADHD. And with that, I'll turn it over to Dr. Harms.
Great, thank you, Keith. So this is definitely a topic I enjoy talking about, so I'm very happy to do this again and talk as long as people are willing to listen. So if we can just get the presentation pulled up, we will go ahead and get started. There we are. So all right, so when we go to the first slide, so I'm Dr. Greg Harms. I'm a clinical psychologist in Illinois, and then licensed in several other states as well. So I do a lot of the evaluations for ADHD to confirm an initial diagnosis to kind of kick off the treatment of ADHD. And so when I was initially approached to do this the first time, I thought it would be a good idea to kind of go through what is the clinician's thought process when diagnosing ADHD, because then that can kind of help people who are considering, should I pursue this further? I think I might have ADHD. I'm not sure. Is it worth looking into? To kind of help your clinician, whether it's myself, whether it's your family doctor at home, whether it's the therapist you've been seeing, to really kind of help them be able to fully understand and help you figuring out, is this ADHD or is it possible that it could be something else as well? So we can go on to the next slide. So, all right. So obviously, if we're all here, we kind of have an idea of what ADHD is. But kind of beyond all the specifics of the diagnosis, I really just kind of like to go over just kind of why it's important to be aware of it, the impact that it has. And I know a previous panelist from earlier this year had described it in their presentation as ADHD is something that just robs you of the ability to be present. And that really is true. So your mind is kind of everywhere except for the here and now, which then obviously causes a lot of difficulties and complications throughout one's life if that's not addressed. So it's a very pervasive condition. I'll talk about that a little bit more later. It starts in childhood. It may not always be fully apparent, kind of depending on what's going on around the child and the environment that they're in. But a lot of times people will tell me after they've been diagnosed, kind of looking back, they're like, yeah, I really saw this in kind of like nursery school, kindergarten, first grade. I'm shocked no one else kind of saw this, but it was definitely there. And it really kind of goes in multiple areas: school, home, friendships, work, and a little bit later in life, and has impacts just about everywhere. So that obviously creates significant challenges just in terms of being able to connect with people, to learn new things, to kind of achieve things, to get things done. It can be diagnosed for the first time at any age, and I will talk about that in more depth a little bit later. I know there's a lot of misconceptions out there about that, including by some people that quote unquote should know better about that. It can be diagnosed at any point in the lifespan. And then we do know it's really disproportionately diagnosed in boys during childhood compared to girls, I think by about a 3-to-1 margin. Estimates are the prevalence is probably more about half and half, of boys tend to get diagnosed a lot earlier and a lot more often compared to girls, for a lot of reasons that I will also talk about in a few minutes here. But getting into adulthood, kind of that late teens, college, early working life in the early 20s, that disparity starts to shrink. I think it's more about like 55% male, 45% female in terms of diagnosis. So it's a bit more evenly split there. Whether that's because females finally get diagnosed and it gets caught, or whether it may mitigate more in boys and they kind of grow out of it, which for a long time was kind of the assumption that that was kind of what was supposed to happen, although we know now it really doesn't. That still we don't know, but there is more of that split in adulthood. So, all right, next slide, please. So, all right, so as a clinician diagnosing ADHD, really the big thing that is key is that age of onset, the time that it starts. And so this is where I think other clinicians who aren't fully trained can get tripped up, is that if the symptoms had to have started in some form before the age of 12. Even if they don't always get fully noticed, not brought to someone's attention, like I said earlier, looking back, you can see that they were there before the age of 12. And so that really is kind of the first thing I look at when I go through an evaluation, is seeing when did these symptoms truly start? Not just when they got noticed, when did they start? If the problems did not start until after the age of 12, it's usually something else that is causing those. And then, as I said earlier, the difficulties need to occur across multiple life domains. For adults, usually you are going to see that. It is going on at home and at work, in other social settings like church or professional associations, or even just with friends. You're kind of seeing those. It's more prevalent with children that there can be difficulties in one setting, but then not others, in which case then the problems are more likely due to something in that setting. Like the child is having difficulty at school, but then at home is getting the homework done, gets their chores done, kind of does just fine, following instructions, isn't losing things, that is much more likely going to be a problem just at school. Maybe they're getting bullied, maybe there's some vision issues and they're in the back of the room, they can't see, they get bored, things like that. So we do want to see, again, that pervasiveness of the difficulties. The difficulties will also manifest in multiple ways. So it's more than just not paying attention or having a lot of energy. All those are kind of the key features, but then there's a lot of consequences of that. In terms of, losing things, forgetting to pay bills and having, financial consequences because of that, constantly getting locked out of online accounts and having to reset the passwords, just kind of going with having a lot of energy, just kind of being restless, not being able to sit still, causing just a lot more difficulties that way. And then the difficulties are not solely due to another condition. So a lot of times there's co-occurring conditions. We know that bipolar disorder has about a 33% overlap with ADHD. That can definitely exacerbate problems. It causes problems of its own. Some of them can look like ADHD, but they're not the sole cause of the problems. Especially with bipolar disorder, the manic phase will kind of go away after a couple of weeks. And so some of those behaviors will then tone down, but the ADHD hyperactivity is still going to be there kind of going on consistently. So that's usually kind of how we rule out a lot of those other co-occurring conditions. We want to see that timeline, but again, usually it's the ADHD first in childhood, and then a lot of these other co-occurring conditions will start a little bit later, whether it's OCD, depression, anxiety, bipolar disorder. Those kind of tend to happen a little bit more down the road. So they're not the total cause of whatever problems are going on. So, all right, next slide. So, all right, so I just wanted to throw in some statistics there for ADHD online, kind of looking at who is coming in to get assessed. So it's about a third male, 2/3 female, which I think really kind of fits with knowing that there's that much bigger split early in childhood. I think we tend to get a lot of women that did fall through the cracks, didn't necessarily kind of get it noticed or had intervention earlier on, and now we kind of finally offer them this outlet to kind of finally get this addressed and get it assessed with clinicians that really kind of know what they're doing, that are going to pay attention, and be able to give them some answers. And so then we can see then that the diagnosis breakdown is just about the same. About a third male, 2/3 female, about 1.5% of individuals who do not identify with the traditional binary gender. And so that really kind of holds up across who's coming in and then who's getting diagnosed. Then for ages, we don't really have a lot of children or even teenagers. My assumption is that really is because at that age, there's a lot of supports within the school system for getting them hooked up to get an assessment done and getting the diagnosis. So there's a lot of other avenues available, either for free or at a lower cost as well. And a lot of times too, kind of outside the school system, a lot of state insurance programs will still cover children. So either the children are covered under their parents' insurance, or they've got Medicaid or public aid through the state that can get the assessment covered as well. We tend to start getting people more kind of college, first job out of college, early adulthood and up. When they are then on their own, maybe they finally have their own grown-up doctor, can't get the records from early childhood, and the doctor would like a new assessment. So we'll get a lot of people in that boat. Or now that they're on their own, a lot of the structures that help support them to manage the inattentiveness, manage the hyperactivity, and kind of minimize the problems that come with it are now gone when someone's living on their own. It's becoming a lot more problematic, and now it's kind of apparent they need to do something about that. And so that's kind of the age range that we get. And then 51 and up, it's definitely a little bit lower as well. Usually the ADHD is going to have been caught at some point by that time. So if they're coming in, it may be, again, my doctor retired, my new doctor wants new evaluation, or it may be, again, there's a major life change, and now I'm seeing that there's these problems, I'd like to get this addressed, but that's a little bit lower. But again, we can see with the percent diagnosed, those percentages really also hold up fairly well. The vast majority of individuals coming to us who get diagnosed with some type of ADHD are in that 20 to 50 age range. And then I will say too, I did the math, and it looks like about 75% of individuals that come to us for an assessment end up getting diagnosed with ADHD. So that really just kind of drives home the point that if there's a question about it, if you're kind of wondering, do I have ADHD? Should I get this looked into further? The answer is a resounding yes. Definitely look into that further, because there's a high likelihood if something's bothering you that much that you're really considering this, there probably is something going on that you may then be able to get help for once that's identified. So I do think it's worth kind of following up with an assessment if there is some question about ADHD. So next slide, please. So a big question that I get a lot across various settings, not just with ADHD online, is ADHD different for women? Because I know there's a lot of kind of social media material out there, talking about that. There's a lot of other outlets out there talking about that. My answer to the question is no and yes. So I say no, it's not different for women because at the core, there's the same set of inattentive and hyperactive symptoms that need to be seen or need to be experienced in order to meet the diagnostic criteria. There's not one set of criteria for men and a different set of criteria for women. It's the same for both men and women, or boys and girls. So when diagnosing ADHD, there's a set of 9 inattentive symptoms, which is basically like difficulty with paying attention to detail, difficulty sustaining attention, not really listening well, not finishing tasks, not starting tasks when it's anticipated it's going to take a lot of effort or a lot of cognitive energy to do that, forgetting things, losing things. There's a list of those 9 behaviors. And then there's 9 hyperactive symptoms, which is that restlessness, difficulty staying in your seat, blurting out answers, difficulty waiting your turn, interrupting conversations, things like that. And to get a diagnosis of ADHD, you need to have at least 6 either inattentive or hyperactive symptoms to get a diagnosis. For adults, you only need 5, but usually it's going to be 6 for children. So you've got to have those, or you have to have 6 inattentive and 6 hyperactive as well. But it needs to be 6 of each. It's not 3 and 3 to get a total of 6. So those are the same, but where we do see a difference, the experience of ADHD can be very different. Because women are more likely to have more of the inattentive symptoms, men are more likely to have more of the hyperactive symptoms, which again is why we see that much higher prevalence of diagnosis in boys in childhood, because those are the behaviors that get seen in school, in social settings, even at home, and get brought to someone's attention. And then even though within the inattentive and hyperactive types of symptoms, there can be different clusters of symptoms as well between men and women. So it can still look a little bit different from a woman with inattentive type and a male with inattentive type. The exact 6 or more symptoms that they have can still be different. And then there are definitely different types of secondary problems or co-occurring conditions between men and women. So secondary problems are kind of problems that happen because of the ADHD. So it can be, I know I can't pay attention. I've got this big test coming up. I'm really anxious about it, which is not the same as having an anxiety disorder. Or, I kind of look back on my life. I've got all these unfinished things. I can't really connect with people. I kind of jump from job to job, even just getting through the day. I always have a to-do list of unfinished things, and it's really kind of lowered my self-esteem, and I feel down. Again, that's all because of the ADHD. It's not necessarily a true, major depressive episode. And so things like that will resolve when the ADHD is treated. So we kind of call those secondary problems, or conditions that are secondary to the ADHD. Co-occurring conditions are indeed a separate condition. So unfortunately, there is no cosmic law that limits all of us to just having one condition or one problem in a lifetime. So we can have multiple different conditions, all of which would need to be treated. So it is possible to have ADHD and a full anxiety disorder and a full depressive disorder. Or, as I said earlier, you can have ADHD and bipolar disorder. There's that 33% overlap. And those conditions will persist even when the ADHD is treated. And so you really kind of have to treat all of them in order to maximize the improvement. So men will tend to have more acting out problems going along with the ADHD. Whereas women will have more of the emotional anxiety problems, like I'd said, just kind of low self-esteem because of the problems that the ADHD is causing, or anxiety because the ADHD is going to cause a problem for something important. Whereas men will have more of the behavioral problems, kind of that difficulty sitting still, kind of more disrupted relationships, probably more legal problems, maybe more substance use issues, kind of things like that. And so then the consequences of the ADHD are then going to be different because of that as well. And again, it's often due to different gender roles. Women have to take care of the kids and maybe work, and they're kind of socialized into this role. And so if you're inattentive, not paying attention, there's a lot more societal judgment. Men may actually get praised for more of the acting out behaviors, may get more social acceptance because they're being more masculine, more macho, and there may be kind of some more secondary gain from having those. But then they also may end up with more legal problems from some of the acting out if they're getting aggressive, being in fights, shoplifting, driving too fast, or driving recklessly, and things like that. So we do see kind of the life courses for men and women with ADHD kind of going in different directions. So that's why I say no and yes to that question. All right, next slide, please. So then, obviously, we know there's a lot of kids that get diagnosed with ADHD, but adults can have ADHD as well. And this is kind of where I want to focus a little bit, because as we saw, this is the age group that tends to come to us at ADHD Online for a diagnosis. So ADHD absolutely 100% can be diagnosed for the first time at any age in the lifespan. So you do not have to have been diagnosed as a child in order to get diagnosed as an adult. And that's one of the big misconceptions that are out there. An adult can be diagnosed for the first time with ADHD, as long as they have meet all the criteria. So the one difference is, I said a little bit earlier, for an adult, you only need to have 5 inattentive or hyperactive symptoms to meet the diagnostic criteria instead of 6. And I believe the new version of the DSM actually took out that first diagnosis specifier. So now, even if you're being re-diagnosed in adulthood, you still only need the 5 symptoms. In a previous edition of the DSM, it was if the first diagnosis was in adulthood, you needed 5. But if you had been diagnosed as a child or even diagnosed earlier in adulthood and you're getting another assessment, you had to have the 6. But now it's just 5 across the board for adults. But, and this is where there can be a lot of confusion, the difficulties had to have been present in some form prior to the age of 12, even if you're waiting until adulthood to get that diagnosis. So you have to be able to look back and see, yeah, I had difficulty paying attention. I zoned out. The teacher often had to call my name 3 or 4 times before I would respond. My room was always a mess, no matter how much my parents yelled at me, no matter how much they withheld my allowance. I just couldn't get my room organized. We have to kind of see things like that looking back. They have to be there. ADHD does not appear for the first time after the age of 12. That hasn't been there. So now I will say there is, if you look in the DSM, which is the whole list of like mental health diagnoses that psychologists and psychiatrists use, there is no specific diagnosis of adult ADHD. It's just ADHD. It can be diagnosed anytime in the lifespan. So like I said, adults can have ADHD. What there definitely is not, though, is there is no such thing as adult onset ADHD. If attention or the hyperactive impulsive problems show up for the first time after the age of 12, something else is causing them. And that, I think, is kind of one of the big things I hear a lot from people when I say, no, this isn't ADHD. A lot of times they'll say, well, why don't you believe me? And it's not that I don't believe you. I go into these assessments fully 100% believing what the person I'm assessing is saying. We've got to kind of have that mutual trust. So I'm not going to say, no, you're making all this up. It's not a problem. I fully 100% believe, yeah, there's something going on with attention. We can see it here. Or there's something going on with impulsivity or hyperactivity. Like we can see that in the information. But what I am going to say is that ADHD is not what is causing these. There are many other conditions that can also cause difficulties with attention or difficulties with impulsivity and hyperactivity, or just what I call self-regulation in general. And so if the difficulty showed up after the age of 12, it's usually one of those other things that is causing it. So with adolescents, if they're suddenly starting to show problems with attention or having those self-regulation difficulties, it usually is substance use. So it is so important for any parents out there. You really have to know where your kids are, know what they're doing, know who their friends are, know the parents of their friends, really kind of pay attention to what's going on with them. They will hate it, they will push back on it, and then when they get into their early 20s, they will appreciate it, that you kind of really paid attention and gave that structure. For adults, if you made it through adolescence, you're not really using substances, never really had a problem with that, and then the attention problems start to show up, or that hyperactivity, impulsivity shows up, there's a lot more potential causes. It could be substance use, that does develop a little bit later in life, but it could also be issues with poor sleep. It could be stress. It could be another type of cognitive impairment. If you played sports in high school and college and had a lot of concussions, they might, those could then start presenting as cognitive difficulties a little bit later, as well into your 20s. So there's more things like that. And then that also is when some of those co-occurring conditions that I'd referred to could start showing up as well. Anxiety, depression, bipolar disorder, obsessive compulsive disorder. Those will show up a little bit later. And so again, if you're seeing this stuff for the first time after 12, it's likely something like that that's going to be causing those attention difficulties. So here at ADHD Online, we're pretty much giving you a yes or a no in terms of, is this ADHD or not? We can screen for a lot of this other stuff, and I will make recommendations as to what to look at more closely to see what's causing it, but we don't really do a full deep dive to come up with that specific diagnosis of, it's not ADHD, it looks like it is obsessive compulsive disorder, or it looks like it's severe sleep deprivation. We don't get the full information to do that as well. And I think that can be somewhat frustrating, but I will try to at least suggest these might be some things to look into then, because we know it's not ADHD because you didn't have these before the age of 12, or they're just showing up in one setting or something like that. So maybe find a neuropsychologist or a psychiatrist and talk more about these things. And it's likely going to be one of these is causing the issues. You treat that with kind of that condition's recommended treatment format, and you are likely going to see a huge improvement in the attention or some of that hyperactivity, impulsivity behaviors as well. So, all right, next slide, please. And then a little bit later in life, kind of what we used to, or we euphemistically call, kind of older adulthood, older adults, just aging. The closer I get to that category, the more I hate those phrases, but those are kind of what we use. Again, even someone in their 50s, 60s, beyond can still get diagnosed with ADHD. And I think that's important because generally when someone in that age range was back in school, was a child, ADHD really wasn't on anyone's radar. It was bad behavior was seen as like a moral issue, usually with very specific ways of trying to address it that were very likely counterproductive. It wasn't really, I think, in like the 70s and 80s that ADHD as a real true health condition finally started getting onto people's radar, and probably not even really into the 90s that it really kind of started getting taken a lot more seriously. So I really welcome, people, again, a little bit farther along in life than I am. If you really think that this is an issue, absolutely come in and get it assessed, because then we can do something about it at this point. So the biggest complication, though, for a provider trying to diagnose someone in some of those age ranges is that timeline and establishing the age of onset. Memory it doesn't get better as we get older, is what I will say. So we may have more difficulty remembering childhood, kind of remembering the exact age at which certain events happened. If there was a lot of trauma in childhood or something, we might have blocked a lot of that out and not really remember. So it can be much harder to establish that clear timeline. So I really would encourage someone in that age range who wants to do this evaluation, try to see what collateral information you can get before starting the evaluation. Did your parents keep all your report cards, back in the day when they would grade like conduct and deportment and things like that? were you a check minus or a minus instead of like a plus? Um, you know, there can be a lot of information there. You might have comments written from the teachers, that might say, he doesn't sit in his seat. He's always getting called to the principal's office for discipline because, he can't keep still or he won't talk, is always all over the place. There could be family stories as well about, yeah, you remember when you were a kid, we couldn't take you anywhere because you would always run off. So I had, one I did a while ago that really reminded me of a friend of mine, that the family story is, yeah, remember that time you got lost and then we finally found you at the service desk and you were just sitting on the desk chatting up a storm to all the employees there and they just loved you and thought you were hilarious. Stuff like that. Your siblings might remember a little bit more as well. If they went through school around the same time, they might have remembered some of the stories as well. And so they might give you some more of that information to build that timeline. And then again, the other big complication a little bit later in adulthood is that there has been more time for life to happen. And some of those other confounding factors might have set in as well. So there may be more true co-occurring conditions. So if you could have ADHD and depression and anxiety, you've had more concussions, had some head trauma. And again, we need to see that full timeline that the attention difficulties really started first. Everything else is kind of added on over time. So we really have to get that timeline. Next slide, please. And then the other big thing that, again, we kind of hear some of that frustration with providers thinking because you weren't diagnosed in childhood that you can't get it now. We may have seen people really kind of manage the difficulties, not necessarily knowing it was ADHD, but their parents were getting reports from school and then they saw the kid kind of running around, and the Sunday school teachers always rolled their eyes when they dropped the kid off for Sunday school. And so the parents may have started providing more structure, giving you what I call scaffolding to be able to kind of manage that. And then, you kind of get married, you have structure, because there's someone to help you out. As kids, they drive you nuts when they're young, but they can help you out a little bit more as they get older. You've got that support. And then something might happen that just takes that scaffolding away and the true extent of the problems start to come out. So it could be divorce or the loss of a partner, could happen, some sort of trauma could happen that kind of reactivates a lot of the problems. It could be a job change. I was very comfortable in this job. I did it for 30 years and then I got promoted to a manager and now I don't know what I'm doing and my desk is a mess. I'm not following up with anyone. I'm getting yelled at from other managers. My job's in trouble. It could be something like that. Retirement actually can really highlight, that how successful structure was in managing some of the symptoms, because now there is no schedule, there is no structure, and it's a lot harder to kind of remember to do things, to find things. And then your spouse then is around and kind of getting sick of you being underfoot because you're losing things and kind of need their attention and help. So that can really start highlighting the true extent of some of these problems. The other big thing, and I'm going to talk about this more on Monday, is sleep deprivation. So it is true that older adults need less sleep than they did earlier in life, but it's, oh, bless you, it's only a little bit of sleep loss, not a lot. So if an older adult is getting 5 or 6 hours of sleep, that's not enough. But a lot of times physicians will say, oh, that's normal at your age, and not really do anything about that loss of sleep and the sleep deprivation. And again, that can then start to look like ADHD as well. So that's one of the things that the attention problems are starting later after the age of 12. Sleep is also one of the things I want to look at. But again, if they were there and the sleep problems are happening, they can kind of get written off as well. So we do want to take a look at sleep. But again, if we can kind of clear up any questions about the timeline, even regardless if there are co-occurring conditions, if there is sleep deprivation, if those problems were there in childhood and we're still seeing those behaviors, they're causing problems, and they're occurring in multiple settings, we can still make that diagnosis of ADHD. And there still is going to be plenty of time to get it treated, make some changes, really improve that quality of life, and really kind of enjoy, whatever amount of time, we are left to have, and really make that as fulfilling as possible. So I believe that's the end. The next slide should just be, I think, the references. Yep, so those are the references that I kind of had in here. So if we have any providers on the call want to get more information, I really do recommend the last one, the Sibley et al. Article. It's a really good discussion of talking about what else it could be if the attention and impulsivity problems show up after the age of 12. It's a really good review of a lot of the literature. And then some of these other ones definitely are can be good for just really anyone that if you want to kind of read a little bit more about it and kind of see what's the difference between true ADHD that's being diagnosed for the first time in adulthood versus something that's starting in adulthood. So with that, I think we now should hopefully have a lot of time for questions. And again, I'll be going into more details in some of this on Monday, but I'm definitely happy to get started answering questions and talking about this stuff now. So Keith, what questions do we have?
Great. Well, let's, I just want to say you were talking about the later in life diagnosis. So self-confessed 49-year-old diagnosed in the last 6 months, combined type. It's really interesting, all the things you were saying, because it resonates with me in so many ways. And actually, I was kind of nervous to tell my family. And as soon as I told them, my brother's like, I could have told you that years ago. And so I was like, well, how come no one ever said anything? So it is a really, it is a transformational piece of understanding yourself. So I don't want to spend time on that, but I just can say I really relate, and I would encourage others, if they're wondering, to look at getting assessed. So we've got a question from Callie. She said, how is OCD related to ADHD?
Yes, OCD is probably kind of next to ADHD as one of the symptoms that really most robs you of that ability to be present, because your mind is just really, again, obsessively thinking about something else rather than kind of what's in front of you. And so if you're not paying attention to that environment around you because you're thinking about, did I lock the door? Did I turn the oven off? Did I say something that got someone mad at me? Do people think that I have a body odor? Things like that. You're not paying attention. So of course, if someone tells you something, you're not going to remember it. Or you might not realize where you're going and end up getting lost, and things like that. So you're going to have kind of a lot of those associated problems that come with ADHD. And it can look a lot like ADHD, even though it's a very different experience and a very different type of presentation. And I will say, usually what I see, again, when the symptoms start popping up more in adolescence or adulthood and there isn't substance use, that very likely is going to be onset of OCD. If there is especially if it's more the inattentive type, not the hyperactive type, which is then probably going to be bipolar.
Right.
And again, it's a completely different treatment regimen in terms of medication as well as behavioral strategies. So trying to take ADHD medication for OCD is not really going to do anything. It could cause more problems than it solves. So we really want to nail that down to get the right treatment.
Right. And I know you mentioned the comorbidities don't always clear up just because treating the ADHD. Callie also mentioned her daughter was just diagnosed at 9, which helped her come to her diagnosis as well. Do you hear that often, where the child's diagnosis around a neurodiverse condition ends up having the parent then say, oh, yeah, maybe me too?
Oh, absolutely. Yes. I mean, that's a good chunk of the evaluations I got from adults, is that my child was just diagnosed. I have always seen myself in my child. They're exactly like I was at that age. And so that really got me thinking. And yeah, I'm still having a lot of these symptoms, having a lot of these problems. So I'm wondering, is it could it be ADHD, and then can I get treated and, hopefully see the improvement that my child is starting to see. So absolutely, we know there's a very strong kind of familial relationship with ADHD, whether it's genetic or it's some of it can be learned, combination of both, whatever. We really do kind of see that across families. And again, because ADHD may not have been on the radar back when a parent was in school, kind of depending on where they lived and when that was, having the child identified really can be a good kind of wake-up call that it doesn't have to be this way for me anymore either.
Right. Great. All right. Well, Jason had a question. Do stimulants like medication or even caffeinated energy drinks have the same effects on the body in someone with ADHD as they do with someone without, i.e. increased breathing, heart rate?
Yes. So I'm not the biggest medication expert. So I am going to throw that disclaimer out there. So I'm not licensed to prescribe in Illinois, but there is a lot of research on the effects of medication. Stimulants do kind of across the board, ADHD, non-ADHD, tend to have very similar effects. So they do have some physiological effects in terms of increasing heart rate, increasing blood pressure, dilating the pupils, kind of, reducing blood flow in the extremities, things like that. It can improve performance as well, again, even in people without ADHD, which is partly why there is a huge potential for abuse, especially among college students. But there seems to be just that little extra boost for people with ADHD that comes with it, that they get just a little bit more out of it in terms of that ability to focus, kind of reducing some of the other symptoms. Whereas for someone without ADHD, you might get actually a bit more of the impulsivity or the kind of externalizing behaviors, even as that focus also gets improved. So that's why it used to be, a diagnostic test would be you do a sustained attention test, take a stimulant, take it again, and if you do better, you probably have ADHD. And then more studies show that's not really accurate. Everyone does better after the stimulant with that.
The way I've heard it described, another one of our providers who's a physician talks about sticky brakes with the ADHD brain and how stimulants act to kind of free up the brakes. And so that ability to get into focus versus not focus, whereas a typical brain, that stimulant is it's gonna need more and more, and with the ADHD brain, there's a little more possibility to regulate. Again, I'm not a clinician either. I'm just speaking from the things I've heard, but
I like that.
There's a lot of history there, and I think he says, that's for him, that was the easiest way to describe it. It made so much sense to me. And when you hear people, I know on our podcast this week, the host Lindsay and her guest both talked about like brain fog, and when they started treatment with stimulants, feeling like suddenly this fog lifted and they had an ability to focus, that where before it was like just juggling a whole bunch of things in your brain. So, all right. Well, we had an anonymous question next. What's the best path to go about getting a diagnosis? I meet the criteria according to the DSM, and symptoms go back to when I was at least 4 years old. I feel frustrated and impatient in my pursuit of a diagnosis. We hear this a lot. That's actually what created our company.
So I said the best path to get that diagnosis is just open up your web browser and just go to adhdonline.com. I mean, there's a button there or something, you just click to get started.
Start the assessment, because it will take you through the same process that a physician recommending you for ADHD testing in a local facility, to essentially the same test, following the same criteria. You're going to spend about 60 to 90 minutes filling it out. But then one of our psychologists, like Dr. Harms, reviews them and provides a diagnosis back quickly, usually within about 3 to 5 days. So we're very proud of that.
And I will say, I know I said this last time, when I first saw like job postings for ADHD online, I'm like, I'm not really sure about this, but I definitely want to learn more. And the more I've learned,
Right.
I'm like, absolutely, this is so comprehensive. I feel really confident making, this diagnosis kind of with the information I've gotten. I said, I think the one drawback is if it's not ADHD, we're not really able to say what else it could be.
Right.
And then we'll make suggestions. But if it is ADHD, I'm really confident when I am like clicking that button that yes, this is ADHD. I have no questions. There's
Yeah.
nothing else I would want to know,
Right.
which I think is really what sets us apart from some of the other more recent telehealth competitors out there.
Yeah, I mean, our model really splits. I mean, I'm glad you mentioned that because we deliberately split assessment and diagnosis from treatment. So
Mm-hmm.
you're not, as a whoever's diagnosing, they're not under pressure to
Mm-hmm.
say everyone has ADHD or, it really is your
Right.
clinical judgment. And then the provider doesn't have to guess if that person has ADHD or not, or try to make some subjective quick assessment and then get them into treatment.
Right.
So,
And what I like too is, and that assessment is so comprehensive. Like if you want accommodations for, like the GMAT or the LSAT or something, you really should be able to get that, like with the assessment that we do, which again, you may not necessarily get from some of the other telehealth providers out there.
yeah, no, it's true. Well, there was a question from Ellen in the chat. She said, "Are assessed and diagnosed percentages the same across other or broader samples?" Like, we've talked about this internally sometimes, like our 60-40.
Mm-hmm.
A lot of people are surprised by that because of the number of women. And then I've talked to some providers that say, well, that doesn't surprise me. We know women have been underdiagnosed for years. I think you
Mm-hmm.
touched on that, but what else would you mention in regards to that?
Yeah, I mean, I don't really know of kind of any other samples out there. This was, I had asked someone, if we could get the data just for our total numbers, like the total numbers in those, of gender and age group that were assessed, and then the total number that got some sort of ADHD diagnosis.
Yeah, and I mean, over 65,000 people have come through the assessment. So
Mhm.
I mean, it was statistically significant
Oh
size in
yeah.
terms of the population. And, I think that's one of the exciting opportunities for us as we move ahead is to see how we start to use that data to open it up to research and understand
Mhm.
more about ADHD.
Yeah, there's a lot of data to be mined there.
Yeah.
So just all I know is like with the numbers I was given, it was about that 75% of people coming in for an assessment got a diagnosis, and it kind of broke down into those categories.
Yeah. Karina had a question in the chat. She said, what are some common misdiagnoses for ADHD? Is there a relationship with borderline personality disorder?
Yes, because that is kind of one of the big things that I think I just touched on without a lot of detail is that early childhood trauma really can also mimic ADHD in a lot of ways because it can be marked by just kind of like, blocking things out, kind of forgetting things, maybe kind of going a little bit more into like a trance or kind of like blackout state when the bad things are happening. But can cause a little bit more just kind of excitability, nervousness, more of that agitation at school, kind of that discomfort in a safe environment. And so you're kind of always on the lookout for threats, again, pulling your attention away from the present. So trauma definitely can also mimic ADHD. And we know that there is a very strong relationship between early childhood trauma and a diagnosis of borderline personality disorder, a little bit later in life as well. And again, I think there could be a lot of those same behaviors of some of that dissociation, a lot of that kind of emotional arousal kind of narrows your attentional focus, and you're not fully paying attention to things around you. You're focused just on one thing. So again, if someone's talking to you and you're kind of focused over on something else, you're not hearing them talk, and that can look like ADHD because then you're not going to remember what they told you later. But that really is driven more by that emotional experience of the borderline personality disorder.
Great.
And then, yeah, I think some of the other ones are the ones we talked about before. Bipolar disorder, it does co-occur a lot, but it can be misdiagnosed. OCD, again, can look like ADHD. That might get diagnosed. And OCD is so hard, can be very hard to detect. If it's not one of the more behavioral ones, if it's more obsessing just in your head, like, did I make someone mad? Which is a very common obsession. That may not get caught right away either.
Right.
So that can be a misdiagnosis.
I mean, that makes sense. Well, so I want to jump ahead on a question because this is related to what you just said. Joss asked, why is bipolar and ADHD so similarly diagnosed to the point where it can be a major problem for the patient?
Yeah, so I don't know, and I don't know that anyone fully knows kind of what the shared pathways in the brain are that kind of activate both conditions. And again, it likely has to do with more kind of arousal. The differential in diagnosing, and this is always what I kind of look at, is that with ADHD, the behaviors are going to be constant, like everywhere, all the time. Bipolar disorder, as implied by the name, kind of goes in cycles. So you'll have a depressive episode, and then it usually, in the classic presentation, it's like a year to 2 years later, you then have a manic episode. And then the manic episode is, a week, a couple of weeks. Hopefully, if it gets treated, it's even shorter than that. If it's not treated, it will kind of start to burn itself out, although usually not without a lot of damage happening. But it'll be over in a couple of weeks, and then you're kind of back to normal. And then a year or two will go by, and you get the depression. Then a year or two, and you get the manic again. It's not, bipolar disorder is not, you are up and down over the course of a day. That can be any number of other things, but that's not the classic bipolar disorder. So I think a lot of times if someone is coming in a manic episode, that can look like a hyperactive or impulsive ADHD. Or someone with ADHD who's coming in with that hyperactive impulsivity, that can look like a manic episode. So again, as a provider, we want to see that timeline. How long has this been going on? Again, did it start in childhood? Because bipolar disorder usually doesn't. Or if it does, it looks different. So again, is it that constant over time, or is it coming in a couple week bursts, like every year or so, or longer than that? That's really the distinguishing part. But if you're seeing someone at just one point in time without any history, just again, because of kind of a lot of ADHD not being on people's radars as long, a lot of portrayals in movies and popular culture and whatever, most providers are going to think, oh, this is a manic episode. And it's really incumbent on them to take the time, even if the person's not able to give a history, try to get collateral information, like call a family member, call the spouse, try to get more of that information to get that bigger picture of the functioning over time.
Okay. She had a follow-up question. So when those who are seeking treatment but get many different opinions from doctors, anxiety, bipolar, ADHD, and it continues to go untreated, what can be of help to them? Like when you're getting mixed, different variables coming at you from different trusted sources, where do you start?
So again, it depends on the timeline, and this would be a conversation to have with those providers. Like if you're looking back to childhood and seeing this, in my opinion, and again, I'm not a prescriber, I would say let's start by treating the ADHD. If it's more that question of there are some anxious symptoms, there's some depression, there's some bipolar. I'm not quite sure when all of this started. Then maybe we might want to try treating some of the other ones first. If they get better, it's likely them. If they don't get better, then maybe we want to switch and start trying to treat it as ADHD and see what happens. The other thing too that I will recommend is sometimes, again, if you can't tell if it's more of those secondary problems versus a co-occurring condition, and they're not extreme, like you're not necessarily suicidal or doing like really dangerous impulsive things, and you can see that timeline from my childhood on, the doctor may want to just treat the ADHD first and then see, does the anxiety go away as we're treating the ADHD? Does the depression go away as we're treating the ADHD? Or if it doesn't, then maybe we want to try treating both and seeing what happens. So I really would recommend, kind of in that situation where many people are telling you things, see who you feel like you trust most or who you click with most. Try to stick with one provider, and as long as they're willing to kind of go through that whole process with you and really work on establishing that timeline of the symptoms. I think that's going to be the most helpful.
I think that's great advice. We had a question from Jennifer, and actually, I think it'll be a little bit of a setup for the next webinar, but she's asked for the best resources for those diagnosed outside of therapy. I know you're going to talk about some of those types of resources and different.
Yeah. So if you're getting diagnosed by like your primary care doctor or you're going to a psychiatrist, there definitely are a lot of things that can be done. Obviously, you can do a Google search and there's tons of things. And hopefully the provider that diagnosed you would have some resources. So obviously having a conversation about medication definitely would be helpful. And then you can decide, is this right for me? Is this not right for me? What else do I want to pursue? Or a lot of times, medication will help, but it's not the be all end all. It's not always the silver bullet that it is, presented as, again, in popular culture or in the media a lot of times. So you may want more of those adjuncts. So trying to find like an ADHD coach that can focus more on what are some behavioral strategies that we can do, like creating to-do lists. Let's set up the calendar on your phone to give you alerts. Let's be sure, that you schedule yourself 5 or 10 minutes of downtime when moving from one task to another, kind of doing things like that. There's some apps out there as well, so that you can find that are focused on trying to enhance cognitive functioning by having you do almost kind of like games, but they're kind of tasks that really focus on learning how to sustain attention, learning how to kind of process multiple things at one time. The research is a bit mixed. I will talk about that more on Monday, but those definitely are an option for getting started as well. Or look for a therapist. And Psychology Today is a great resource. You can put in your insurance. You can pick what issue you want to focus on, and ADHD is one of those. Put in your zip code and kind of see who's nearby as well. So I think that's a great place to start. And then hopefully your therapist, if ADHD is a specialty, they'll know then a lot of the other resources in your area or other things you can do to start addressing the behaviors, especially if medication isn't something that you want to try right out of the gate.
Right. And I'll say something else that I've heard. It's not a wisdom of my own, but it resonates with me is medication, any type of medication to treat this is probably mainly around symptom control.
Mm-hmm.
That symptom control is maybe 10% of the work. And that other 90%, this behavioral, the therapy, the other things that you're trying to do, I think that's where a lot of us get tripped up because it feels quite large because it's a big piece of work, but it's also where, you've got to do the work no matter what.
Right, exactly.
Even if you're on treatment for the symptoms, you still have things that it's likely impacting that you've got to deal with. You can't just avoid them.
Yes, exactly. So that's a great lead on for Monday.
Yeah. So, all right. Well, we've got 1 minute left. This was and I apologize that we can't get to all the questions in chat or Q&A, but this was a good one to close on. Jan said, some days are much better than others. Is this common?
Oh, yes. Yeah,
I'll say yes too.
Yeah, because again, the medication is not the silver bullet. So it's not something you take and everything is suddenly fixed. We still have life to deal with on life's terms. And so, yeah, some days are going to be good. We might have less stress kind of going in. So the medication is going to be more effective because there's not as many neural pathways it needs to control. And some days, we may wake up to find, the dog threw up overnight and the kid has an earache and doesn't want to go to school. And so then, we try to find our clothes and find out, the dry cleaner sent, our favorite shirt back with a big iron mark on the back. And it's just not good from the start. That's a lot more neural pathways going than the medication is going to be able to kind of rein back in and get under control.
Right.
Which again is that good setup for Monday.
Yeah.
Life still happens.
Life does still happen. And that's a great way to kind of sum it up for today. So Dr. Harms, thank you so much for spending this hour with us. Thank you to everyone that joined us. Again, I really appreciate all your questions. We do look at all these after. It does fuel the type of content that we put into our blog, into our podcast, which I'll just give a quick highlight to our podcast, Refocused with Lindsay Gunsel. If you haven't listened yet, we would encourage you to, because we're really just letting Lindsay talk to people about ADHD and we're getting out of the way. And so it's a lot of fun to help get that out there. So again, Dr. Harms, thank you for your time today. Thank you everyone for joining us. And we'll see you next week on part 2.
Yes, looking forward to it.
Okay, same here.